Folks, this is the fourth and final session in an educational series being put on by the Healthcare for All Colorado Foundation. Our facilitator is Vince Markovchick. He is a retired ER director for Denver Health, so big job and lots of responsibility, but also tremendous amount of knowledge about the healthcare system and what's going on for us right now. Vince has served on the board of the foundation for a number of years, and thank goodness, because I consider him one of our state's treasures on healthcare education and knowing what policies work and don't work. And so tonight we will conclude our session, and then all of the slides and all of the videos will be posted on our website and also emailed out to each of you who participated. So please take it away, Vince.
Thanks, Donna. Well, the first session, we basically reviewed what our healthcare marketplace looks like, and it's very fragmented and disjointed. And we got an understanding of how all these programs, Medicare, Medicaid, private insurance, Medicare Advantage, how these things work. The second session, we followed the money, the $3.8 trillion, asking where does it come from and where does it go? The third session last week, we covered waste, fraud, and abuse, which is about a $1 trillion problem in our country. And today we're going to talk about how we might be able to move forward and fix some things. So we're going to talk about what is the ideal health insurance and healthcare system. We're going to talk about impediments to reform of this system. We're going to talk about and focus a lot on the case for a publicly financed single payer, enhanced and improved Medicare for all. Just this past week, after last week's session, I became aware through the Physicians for a National Healthcare Program video that there's a new threat to traditional Medicare, and this is truly scary. And let me go through what's going on, because this is wild. What's happening is Center for Medicare Services apparently had some pilot programs out there with people who wanted to become direct contracting entities to Medicare. And they seemed to think, I think they were sold on the idea that these direct contracting entities could somehow save Medicare money. And so they're making these available now in many states, and we'll go through this. What is it? Well, here's the way traditional Medicare works. You have your Medicare card. You have traditional Medicare. You have basically a free choice of doctor and hospital, and there's no intermediaries between you and Medicare. If you have Medicare Advantage, you've turned your Medicare over to a private insurance company. And now you have intermediaries who add little or no value to the whole process. About 1/3 of people who are on Medicare have a Medicare Advantage program, 1/3. Now, what about the other 2/3? Well, the for-profit entities out there have their eye on them, and they're saying, how can we get a piece of that action? And that's where these direct contracting entities come in. So the way they work is Center for Medicare Medicaid will auto-assign members to these DCEs without a preference. They just auto-assign you. You can opt out, but they don't clearly inform you that you can opt out. Most people won't even know they're in this until they get sick and start hitting some of the same barriers they have dealing with private insurance companies. You may not have free choice of doctor and hospital because you now have an intermediary that often will be an insurance company between you and your Medicare. And this is really scary stuff. And so there's three flavors of the direct contracting entities. There's a company called GlowPro, who's really into this big time. And basically what they're doing is they're convinced Medicare that they're going to manage Medicare. And so it's similar to a managed care program. And these were not previously allowed to be involved at all with traditional Medicare. The group of the dual eligibles, the people who are usually seriously disabled, covered by both Medicare and Medicaid, they're going to get in to their coverage. And the most scary one is they were seriously considering Medicare just assigning people to these entities based on the geographical area where they live. Now, there's been enough pushback on this geographic thing that they have not done this. But think about it. This is a way for private entities. And who are these private entities? Well, they're basically provider groups, insurers, and these are just the numbers of them. This is not the percentage here. The numbers of people that are currently in this DCE marketplace. And look at this. There are now a whole bunch of states that have DCEs. Colorado, fortunately, does not have that yet. But boy, it could be coming, and we need to be real careful and watch for that. The non-insurer DCEs are provider groups. For example, any type of large healthcare system that is providing healthcare, like Kaiser, for example, could be a non-insurer DCE. And then the insurer DCEs are the traditional private insurance companies like United Healthcare and Humana and the others. And that insurer DCE, they're in where the most Medicare patients are. So that's where the most money is. But talk about privatizing Medicare. If you add Medicare Advantage to the plus the direct contracting entities, essentially you're going to approach 100% of people on Medicare being managed by private entities, either medical groups or insurance companies. And this is not good. They add no value. They take a whole bunch of money out of the system, as we've demonstrated talking about how Medicare Advantage works. And they will put impediments to healthcare between the Medicare insured person and the providers. So hopefully this can be stopped, but I don't know. We'll see where it's going. This is an old slide from before. You can see that 80% of the people who are insured, or 80% of the people in our country, consume less than $1,000 of care per year. These are the healthy people. These are the people working full time. These are the young people. And then you look at the top 10% of the people consume 73% of the healthcare dollar. And these are these are the elderly people, the disabled, the sick, who are not working, and they're covered mostly by Medicare, Medicaid, or no insurance. And then you've got another 10% that consume 13%. The private insurers are in this marketplace. The public insurers are in this marketplace, and the private insurers love it because they get the premiums and they pay out very little. So what would constitute ideal health insurance? And actually, there are models around the world that have all these factors. Of course, it should be universal. It should cover everybody. In the European countries, the people who are not citizens of their country, they cover them and call them guest workers, because that's what many of them are. They're from other countries, they're employed there, but they're not citizens. So it should be universal. It should cover everybody. It should be comprehensive, and we'll go through this again. It should cover cradle to grave, everything, prenatal care all the way through to end of life care. That would be comprehensive health insurance. It should be portable. You should continue to have your health insurance, whether you're working or not, whether you change jobs or not. Right now, 150 million people are tied to their health insurance through their employer. And you saw what a disaster that turned out to be when so many people lost their jobs when COVID hit. They lost their insurance. That should not happen. Should be portable. Should be affordable. Man, this one. Our healthcare is so darn expensive. Clearly, the average person can't afford it. Fortunately, the average person doesn't get real sick and realize how that they can't afford it and often have to go bankrupt. Obviously, ideal health insurance, you should have a completely free choice of doctor and hospital. And as you know, a lot of our politicians say, well, if you do Medicare for all, Medicare is going to tell you which doctor and hospital you should go to. Medicare is not going to tell you that unless they have these direct contracting entities in the middle and Medicare Advantage. Medicare, you can go whoever you want to see, free choice of doctor and hospital. There are a very small number of doctors and maybe a few specialty hospitals that won't accept Medicare, but that's a very small percentage. Medical bankruptcy will go away. Remember, we talked about 550,000 patients a year declare personal bankruptcy either in whole or in part because they can't afford a medical bill or medical charges. This goes away. It ought to be transparent and accountable to the public. Medicare is, in a way, transparent, traditional Medicare, but the private insurance entities are very opaque. They're not very transparent. And if it's transparent, it's accountable. And if it's transparent, you can identify early on potential fraud. So how do we attain this ideal? And we're going to go through this during the rest of my talk today. I believe we attain it by ultimately passing legislation to extend current Medicare to everybody. Right now, it covers people 65 and over. It covers people who are totally disabled, and it covers your kidneys, no matter what your age. We need to expand that. And Medicaid, of course, covers the people at low income levels and people in nursing homes. And we need to incorporate that into the system and transition it to Medicare also. So we want to approve and expand the existing Medicare. We're going to get into this with all residents in the risk pool, which makes everybody's ability to afford this better. If we did this, there'd be a dramatic reduction in administrative overhead from the 20% of the private insurance marketplace to the 2 to 3%, which is the Medicare overhead. That saves $400 or $500 billion a year right there. If we do global budgeting for hospitals based on their actual costs, this saves billions of dollars. What is global budgeting? It's the way fire departments are funded, the way police departments are funded, and the way hospitals in a lot of other countries are funded. Once a hospital has a global budget, they no longer do fee for service, so all their administrative costs of doing billing and collecting, the temptation for them to commit fraud in billing it just evaporates, it goes away. And now they can just focus on providing high quality medical care, because every hospital in a given community is on a level playing field. And now they compete on quality of care rather than who can move to the neighborhood with the highest income and make the most money. Medicare would be able to negotiate prescription drug prices, which Canada does, which our Medicare is prohibited from doing. Same with medical devices and durable goods pricing. It would set uniform reimbursement rates for all providers. You saw the dramatic difference in reimbursement rates when just looking at the charges we went over last week. You know, for a laparoscopic appendectomy in Colorado, the charge ranged from $21,000 to $92,000, and that's just the hospital bill. It would set uniform rates for all providers, which the hospitals would be covered through their global budget, and the physicians and other providers could continue to do fee-for-service billing, or they could contract as a group as well. And we would have capital spending based on need. You couldn't have a hospital all of a sudden building another hospital in a part of town where the wealthy people live, when there's no reason to add another hospital there. And there would be transparency in both quality measures and cost. Wouldn't it be nice if you're contemplating elective surgery of any kind to be able to go online, since there'll be a single biller who, if Medicare as the single biller, single payer rather, would immediately be able to know where the complications occur, which hospital has, which provider rather has more complications, because these complications and the care they need would be billed to Medicare. So you'd have a transparency in quality measures and costs. You could know how many surgeries of a specific kind of surgeon has done, what their complication rates are. And it will be funded, the additional funds that will be necessary after the savings are taken into account. The funding would be through fair and progressive taxes. And it would cover everybody from prenatal care to end of life. And it would eliminate, never eliminate all, but a lot of our current waste, fraud, and abuse. So let's go through this. The goals of reform with single payer. We want to cover everyone. We want it to be universal. Commercial insurance clearly does not do this. It covers people who have their insurance, and that is, most people are covered through their employer. They don't have a choice of which insurance carrier they have. The employer makes that decision. And it depends on their job, whether they're, the spouse has coverage that they can join into, income, and this can be lost at any time. Medicare for all would cover everyone, regardless of age, immigration status, all of that stuff. They're covered. Does it cover care for all parts of the body? Now, with the reforms of the Patient Protection and Affordable Care Act, there is a uniform policy that's required of private insurers. They can no longer sell junk insurance, but they still don't adequately cover some areas. For example, mental health is not always well covered, and they certainly don't cover long-term care. Medicare would cover, expanded and improved Medicare would cover all medical services. And we'll get into those in a little bit. Do you have free choice of doctor and hospital? We've gone through this again and again. Of course not. If you have private insurance, you got to see the doctors and hospitals that are in their network. If you have traditional or original Medicare, you can go to pretty much any hospital or doctor in the country. Will it reduce costs? Because remember, we need to make it affordable. Commercial insurance certainly will not reduce cost. In fact, we talked about this. They have a perverse incentive to increase premiums, especially now with the increased subsidies under Obamacare. And so they're not controlling costs. They're jacking up their premiums. Right now, the federal government is paying for this increase in premiums. So the patient who's insured or the person insured doesn't sense this, but that's what's happening. Under Medicare for All, care is provided just like in Canada, free at the point of service, and the families won't see bills. Will it reduce overall health spending? Insurers have no incentive to reduce spending, or hospitals have little incentive to reduce spending sometimes. Whereas with Medicare for All, with global budgeting, with controlling the fees, and making a lot of the administrative waste and abuse go away, it would save a lot of money, and we'll get into how much. Will it improve health equities? Right now, large groups of people in the country, and we'll get into these a little later, receive poor medical care because of who they are. We're talking about the Black and brown communities. We're talking about Native Americans. We're talking about immigrants. We're talking about a lot of them. And underinsurance and uninsurance exacerbates disparities because these people simply can't get access to care, can't afford care. Even if they have some insurance, they can't afford the copays and deductibles. And Medicare, truly improved Medicare for All, would eliminate all these financial barriers. And more importantly, it also invests in services and facilities to serve the underserved communities. There's no incentive to do that now because that's not where the money is. And the providers, hospitals and doctors and freestanding ERs, they go where the money is. They don't necessarily go where the need is. Because if they go where the need is, people can't afford to pay their huge bills. So Medicare for All is very simple. You've got the consumers or patients on one side, you've got the providers, the doctors, the hospitals, and the pharmaceutical companies here. Got a lot of money floating out there, $3.8 trillion. You've got all these the current system is these middle people who add no value. They just take a whole bunch of money out of the system and they make your life difficult. Improved Medicare for All, you would have the consumers or patients, single payer paying the providers. There'd be no middle men siphoning healthcare dollars off and interfering with your free choice of doctor or hospital. So that's the free market solution, is Medicare for All. So here's a review of some of the ways this is done throughout the world. National Health Service, public funding, public delivery, and that's like the National Health Service in Great Britain and other countries where the doctors and hospitals, the hospitals and clinics are owned by the government. The doctors, nurses, and all the providers are government employees. And that's the public funded, public delivery model. And it works well. And as we went over, we have those models already in this country. The Veterans Administration is that model. Denver Health is that model. It's a government hospital, owns the hospital and the clinics, and all the providers are salaried employees of the hospital. The United States military medical system is that model. The Indian or public health service is that model. And that is true socialized medicine. That's the evil group over there. We got the Wild West here. We got mixed funding, mixed delivery, high cost, mixed access, fragment and dysfunctional. It's a totally screwed up, dysfunctional healthcare. It's not a system, it's a marketplace. And when it's a marketplace, the whole focus is on how much money you can make, not what quality of healthcare you are going to deliver or provide. And then, of course, we have the national health insurance model. Okay, and that's where you have public funding through public funds, taxes or premiums or whatever it's called. But most of the care is delivered by private providers, physicians, and nurses. That's the model in Canada, Spain, Ireland, and Australia. That's what we have in original or traditional Medicare. It's a national health insurance. It's a social health insurance. It's not socialized medicine. And it applies to market to medicine, and it works pretty well. So, any questions or comments before we go on to this next
And
part?
folks, if you'd like to make a question or ask a question or make a comment, just unmute yourself and go ahead. All right, Vince, I think you're good to go.
All right, I guess that's all. Everybody understand. I know I'm preaching a little bit to the choir here, but that's good. So well, let's go over the current bill in the House of Representatives. It currently has 117 co-sponsors. The major sponsor is Pamela Jayapal from Washington. And it's the Medicare for All Act of 2021. It builds and improves on previous bills proposing Medicare for All. Like the previous bills, it covers all residents and all ages. This is important because we have up to 11 million immigrants in this country who don't qualify for Obamacare and Obamacare subsidies. They don't qualify for Medicaid, and they don't qualify for Medicare, even though they may have been paying into that system all of their lives working. This covers all residents, all ages. It's comprehensive. There are no copays or deductibles. It's funded through equitable taxes, and we'll go through all the options that have been out there and propose to do some equitable funding of this system. And this is important. We talked about this again and again. It has global budgets for hospitals. You want to take away the incentive for hospitals to bill fee-for-service, to bill for every aspirin, every Tylenol, every little procedure that they do. And then, of course, the temptation to upcode and bill for above and beyond the service they really provided. And they have an army of people to do this billing and coding. The insurance companies have an army of people figuring out how not to pay all these bills or to discount their payment or to refuse to allow authorization for tests and procedures. That goes away. This global budgeting is really, really an important piece. And the other thing it'll take away is the huge, incredibly absurd salaries that administrators pay themselves. Because if you now, every hospital is a globally based budget hospital, and they've got to compete on quality, and they got to live within the budget. So if they want to pay their administrators more, it would be pretty stupid for them to start cutting providers like nurses to keep their high salaries for administrators. They have a lot of fat at the top that they could cut very quickly by dramatically reducing salaries and getting just basically suggesting that they don't need all of these other managers. This current bill is a 2-year transition. It would be implemented over 2 years if it's passed. What's new in this bill is more investment in, let's go with this, let me fix this, in health equity. We'll get into what that means in a minute here. More covered benefits, the big one being long-term care, which we'll spend a little time on because it's very important. Prohibition against future benefit cuts. So the benefits that are in this bill cannot be in the future. A new president or administration comes in and they decide they want to cut some of these benefits. It can't be done. And we were so unprepared for this public health emergency. And this prepares the nation for future public health emergencies. And we'll get into how they do this in a little bit. So the improved Medicare part, providing all necessary care. And the improved part is currently Medicare does not cover vision, vision meaning they'll cover cataract surgery, for example, but they don't cover contact lenses or eyeglasses. They cover no dental procedures. And there's a lot of seniors who need a lot of dental care that's gotten very expensive, and they're doing without it. You guys know USA Today about 10 or 15 years ago published a survey on the state with the most edentulous people. It was a close contest between West Virginia and Kentucky. Hearing aids, tests for hearing aids, that's not covered now. And this is the big one, long-term care. Long-term care is covered now. About 60% of people in long-term care facilities have to become indigent so they qualify for Medicaid. And that's how it's covered for the most part. And comprehensive reproductive care. Now, this is going to be awful controversial, including abortions, because this bill will repeal the Hyde Amendment. Care would be free at the point of service, no copays or deductibles. So this underinsurance would go away. People with underinsurance, they can't afford the copays and deductibles. So even if they have insurance, they don't always get the necessary ongoing care to prevent them from becoming very ill and running up a huge bill. And this is a big one. There's no need for people to go out and purchase Medigap or supplemental insurance to cover what Medicare doesn't cover. And of course, there's no reason for Medicare Advantage and the private insurance companies to continue to exist. So that's a big one. And it's equitably funded through some type or combination of things that would be progressively taxed. In other words, the people with low income would pay less. People with higher incomes would pay more to be covered under this Medicare for All program. There's nobody left out. We talked about this, includes everybody residing in our country, regardless of age, income, employment, or immigration status. People who are covered for their entire life. No one is denied care due to pre-existing conditions, and patients have the free choice of practically any doctor or hospital. What else does it do? Well, it's eliminating the out-of-pocket expenses. We went through this. That is a lot of money for families, and it is a lot of money for seniors on fixed low incomes, and many of them simply can't afford this because there's no copays, deductibles, and no private insurance premiums, because you don't have to buy Medigap or Medicare supplemental insurance. There's no paperwork denials or surprise medical bills. Surprise medical bills is getting worse and worse, and we went through in detail last week what's causing these. And this will go away because those for-profit entities will be taken out of the healthcare system that are causing these bills. And because the providers' fees will be set by the health insurance system, and the private equity funds cannot inflate the bills and charge insurance companies and patients. It will eliminate insurance company hassles, because private insurance companies go away, because they provide no value added to the system whatsoever. Zero. I'll say it again, they provide zero added value to our healthcare. They just get in the middle of everything, and they're there to make a profit first and foremost, and it compromises medical care. And it bans this step therapy, prior authorizations, and other barriers to care. There's no need to purchase the additional insurance, which we just talked about. That goes away. And that's a lot of money that people are paying for these additional insurance cover. Well, for Medigap and Medicare supplements, $2,000 to $4,000 a year. The Medicare Advantage, we talked about that. You turn your healthcare over to a private insurance company. You still have copays, deductibles. You may or may not have premiums. There's a huge savings in the administrative efficiency of this single payer publicly financed system. It eliminates the waste and profits of commercial insurance, because commercial insurance will no longer be allowed in the marketplace to provide basic health insurance care. They could still sell secondary insurance if they can find the need for it and people wanted to buy it. It would take away this huge $500 billion cost that it cost hospitals and doctors to do the bill, send the bill out, and the insurance companies to figure out how not to pay the bill. And all of that noise in the system goes away, where you have the providers billing a single entity, Medicare, for the service they provide. And you have the hospitals no longer doing that at all, because they're beyond global budgets. Reduce prices for drugs and devices. One insurance company for the nation will have a lot of leverage in negotiating prices from drug companies that, as we went through last week, are outrageously inflated. And there is provisions in this bill, which is wonderful, to override the abuse of the use of patents that the pharmaceutical companies are using again and again and again to inflate the cost of drugs, to continue with high drug prices. And this is going to be reined in, which is far overdue. And then the global budgets for hospitals. Hospital financing today encourages hospital to chase the most lucrative procedures, and that often is elective surgery, joint replacements, and all kinds of elective procedures, because that's where the Medicare and insurance companies pay the most. They won't chase psychiatric or mental health care because they don't get paid so well. And in fact, in the Denver metro area, virtually every private hospital has eliminated their inpatient psychiatric ward. And there are only 3 or 4 places where you can, I think 2 or 3 now, where you can get someone hospitalized who needs acute inpatient psychiatric care. So right now they invest in the most profitable, they neglect or eliminate the least profitable, but sometimes the most needed services. And this goes away with global budgeting. And the pandemic will no longer create a fiscal emergency. And this emergency was created because the pandemic caused a lot of hospitals to cancel their elective surgery, which is the most lucrative part of their revenue. And that went away. And so, of course, the government rode to the rescue with billions of dollars. And we didn't have time to get into how that was abused and a lot of fraud was committed there. But with this new system, if you have a pandemic creating a lot of strain on hospitals, there is a way to increase the funding to the hospitals to overcome that. So the hospitals will each be paid a global budget based upon the level and the amount of care they provide in a given year. They're expected to live within the budget. They no longer have this incentive for most profitable interventions, and the resources will be aligned now with the community health needs rather than the community money. And it reduces hospital overhead. Remember, all that billing stuff, most of it goes away. Virtually all of it goes away for the hospitals. And hopefully they will reduce or eliminate the bloated administrative budgets that they have for their administrators. It promotes health equity, establishes a new Office of Health Equity to publicly track health outcomes in the people who are disadvantaged and in everyone. It'll address disparities. This is really a problem right now. Because this doesn't pay well, we have a shortage of primary care providers. And because these underserved, disadvantaged populations have no insurance or are on Medicaid, which doesn't pay well compared to other insurers, we have limited or no access to primary care for many people. That will go away because in this bill, there are incentives to promote primary care. The new funding will be needs-based, focusing on underserved in rural and urban communities, and populations who are currently covered in one form or another will continue to be protected. The VA will continue to exist for people who are qualified for VA care. Indian Health Service will continue, and TRICARE. Now, we didn't talk about TRICARE. TRICARE is the military medical retirement health insurance plan. It's the best deal in the country. It's funded through the military budget. It's not funded through CMS or Medicare, Medicaid services. And their premiums are incredibly low. They have not been increased for years and years and years, and people are getting excellent care, but they're paying next to nothing in premiums. And it overrides the Hyde Amendment. There's going to be a little fight there, I would think. The Hyde Amendment, of course, named after the Speaker of the House, and I think his name was Henry Hyde. I don't know if I got the first name right, from Illinois, who subsequently went to jail for being a pervert. But the Hyde Amendment basically says that no taxpayer public dollars can fund abortion care. The groups impacted by disparities, it's a large, large number. But these are all people who are impacted by health disparities and are not getting the quality of care they deserve. And there's a whole bunch of reasons for it, and you can see it here. this is the latest one that's the rage here about gender identity and sexual orientation. And of course, we have a homeless problem, and that's a big healthcare issue. And
Vince, we had a couple of questions. I'm going to interrupt you for a
let me
minute.
stop and we'll take some questions.
Okay. Hunter, do you want to unmute and ask Vince about Kaiser? And then following that, Stuart, I think, had a question too about TRICARE.
So my question, Vince, was if we move to Medicare for all, what happens to a company like Kaiser, which is both an insurer, but it's also a provider?
The insurance company goes away. The provider organization can contract with the single payer Medicare for all to provide healthcare as the Permanente medical group, which they are now. So they would be able to get a global budget, and they would then continue to salary their providers, or they could contract with them as a group and bill fee for service, whatever would work best for them. But the group can stay intact if they wanted it to. The insurance company goes away, and that's a big fight now in California, where the insurance company is really, really paranoid about single payer in California, and they're going through all kinds of contortions to try and continue to exist. But there's no reason for them to exist. They would add no value to the system.
Thanks.
Other
And
questions?
Stuart?
Yes, hi. Thanks for the presentation. This is clear and concise. But I hadn't heard of TRICARE before. Are the providers in TRICARE employees of the military?
No.
Or is that private?
No, they're private care. With TRICARE insurance, you can essentially go to any private provider you want. And so it's a private healthcare. This is a great deal, and it's part of the inflated military budget. They figured out a way, despite the huge inflation in the cost of healthcare, to keep the rates at an absurdly low rate for the people covered by TRICARE. This, I guess, for political reasons, will continue. Actually, they'll be folded into the single payer Medicare for all, but they'll still get, which will give them the same services.
So how are they able to achieve such low rates in this market?
Because the military did it. Because it's a military program funded by the military. And they've said to it's the people who qualify for full retirement that qualify for TRICARE. And they said, you stay in the military for 20 or 30 years or whatever, has to be at least 20 as a payment for your service. We're going to get you this healthcare at a very nominal cost.
So they must retire after 20 years. It's not for
Right.
It's
not anybody who's been in the military.
Okay.
You got to be a retiree, and your family will be covered.
Thank you.
All
Other
right,
questions?
and Lydia had a couple of questions. She was hoping you would re-explain what global budgeting is for hospitals. And then she has another question about stem cell and so forth. So Lydia, do you want to ask, or do you want Vince to go ahead?
Well, I think, Vince, I think you can see the question, but I just wanted you to explain or redefine the hospital global budget.
Yeah, global budget would be like a fire department, where each year, for the subsequent year, the city will or county or whoever's funding the fire department will say, this is what we believe it's going to cost to provide fire protection services. They probably add a little extra money in for inflation the next year, or do any particular capital equipment needs. And they say, this is your budget, and this is, you got to live within that, and you got to figure out how to do that. With hospitals, what they would do I would think would be, they would look at this year, the number of patients cared for in the hospital, the level of care they provided, how many critical care, how many ward patients, how many routine care, how many whatever, and figure out what the true cost of providing that care would be, which would be what what Medicare would provide, and they'll add another percentage on top of that. I've seen 10% as a proposal, 10% above current Medicare rates. And they would say, okay, this is the care you provided in 2021. We believe that you could, here's what it'll cost you to provide that care with our new rates in 2022. And that's the global budget. And you figure out how to live within that budget. If you have a particular capital need, that could be applied for, and this would be kind of like a certificate of need. They need expensive new equipment. They think they need to expand their beds. That would be a separate issue. But the global budgeting would mean that the fee-for-service billing would go away. I can't emphasize how important that is, because that's where all the abuse comes in terms of hospitals. And their huge administrative budget comes from having to do billing and collecting and negotiating discounts and all that other stuff. That goes away.
Okay. And then my next question, thank you, Vince. My next question was, do you know if under HR 1976, if stem cell procedures like stem cell injections or other procedures would be covered?
No, I don't know that they've gotten into that level of granularity, but I would assume they would be, and I would hope the way they would decide what procedures they're going to cover, particularly if they're research procedures, they would do it based on evidence. And I believe they would do their formulary based on evidence. And they wouldn't approve new drugs like the National Health Service in Great Britain does. A new chemotherapeutic agent comes on the market that costs $100,000 a year, and it only prolongs life by 3 to 4 months. The National Health Service says, we can't afford that, and we're not going to fund it. And now that's the dreaded R word, which is rationing, but that really does need to happen in some instances. And while we're on rationing, I took my slides out on that. I should have kept them. The best way to ration healthcare, that is to limit the amount of money we pay for healthcare, is for every person to have a detailed advance directive and living will. Because the huge part of our healthcare costs go to people, futile care at the end of life in an ICU. And if you have advance directives, living wills, a lot of that will go away or be diminished. And that's a huge savings. And that's a humane way to end up rationing healthcare. And I should have kept my slides in for this. I'll do it next time.
Thank
Okay.
you, Vince. It seems like
Thank
a
you.
good day to mention that, since Dick Lamb had his memorial service today. And he got in a lot of hot water many years ago for making comments about
The duty to die. That
Yeah,
was Governor Lamb, the duty to die.
yeah. Karen, do you want to ask your question, or would you like me to go ahead and do it? You can unmute if you'd like. I think I'll ask for Karen. Karen would like you to explain again that in this bill, in Medicare for All, that would there be a need for any kind of gap insurance, or is that gone?
No, that's gone. There'd be absolutely no reason to have Medigap or Medicare supplemental insurance, because the things that they cover would be funded and you'd get through expanded and improved Medicare. For example, the copays and deductibles, they would go away. you would have vision and dental insurance. Now, they don't have in this bill gym memberships and delivering meals to your home and some of those other things that people are using to market, but they have everything that's important, and there would be no reason for supplemental insurance policies. They go away. Okay, let's take about a 10-minute break, and we'll come back at about 5 minutes after the hour, and we'll finish up.
Sounds great. Thanks, everybody, and come back in about 5 minutes.
10 minutes, you said.
Oh, yeah, Vince gave it until 5 after 6, didn't he?
5 after, yeah.
Yeah, let's give it 5 till 5 after. Thank you.
Boy, I'm going to get in trouble, some of the stuff I'm saying here, but that's okay.
Something
It's
tells
great
me
to
you've been
see
in
you.
good
Thanks.
trouble before.
Huh? I got bulletproof underwear, so I'm okay.
This is Kristen Nordenholtz. It's great to see you. Thanks for doing this. Really
Oh, hi,
appreciate it.
Kristen. Hopefully you could tune in on the previous 3 sessions.
Yep. No, you're doing an awesome job. Thank you.
Well, thank you for tuning in, and hopefully you can get the word out and some other folks can get access to this, because my whole goal is to educate people, encourage them to do what I'm doing, and to educate others, because we'll get into this, but the only way we're going to overcome the special interest gorilla out there is to educate people who vote.
Roger that. So listen, I have Vanjie here. Vanjie Murray is one of our senior residents, and she's starting a fellowship called, I'll let her speak for herself,
Oh, boy.
Social Emergency Medicine. Listen
Jason
ahead.
Hocus?
Oh yeah, so I'm working with Dr. Hocus on like a research fellowship, but we want to have it focused on social emergency medicine and social determinants of health. It is with Jason Hocus. Yeah, we're trying to like found a division at Denver Health specifically.
Well, the Healthcare for All Colorado Foundation has stated that we could make some small grants available to do studies focused on what we're interested in. And if you contact Jen Whitworth, she was supposedly, she was writing up a RFP for these grants, and maybe we could work together with you.
Yeah, that would be great.
Can you put the contact information in the chat, please?
You
For Jen?
contact Jen Whitworth
Okay, all right,
at
thank you.
Denver Health.
That's magnificent, because we're getting a lot of interest from the residency group on all of these issues. And today's grand rounds was Dr. Patty Cabot. So
What did she talk about?
what do you think? She said, stop spending money on waste and let's change this, and let's get rid of all the high-end costs and get basically exactly what you're saying right here. She didn't
Okay, well, I've been trying to be able to give this talk to residents, and I haven't been able to do it, but hopefully I
We
will
can
someday.
help work on that.
let's work on that. We'll work on that offline. We definitely have to get you speaking this language to everybody. Thank you very much.
Okay. Well, we'll get going here in about 5 minutes and wind this down. And yeah, I think because medical students and residents are not there's not part of their curriculum because they're so focused on medical care, and I understand that. But they need to know what's waiting for them when they get into the real world.
Great question. Kristen wants to know if you're going to try and get this information out to the League of Women Voters, Vince, and other like-minded.
Well, I would
organizations.
love to. And we need to get it out to nurses.
Yeah.
We got to get it out to nurses, and I haven't figured out how to do that.
Tough when the state nursing group is kind of an impediment sometimes.
Oh, Vince, hey, it's
Yeah.
Shelley. Sorry, I'm so late getting in. It's just been one of those days. But when after the holiday, I want to talk to Colleen. Casper, who's in the head. Sorry about the dog. Scotch. Oh, wait a minute. Scotch. No. Scotch. Go out. He's very barky. Anyway, I wanted to talk to Colleen about getting nurses on board with this. But she's still the head of the CNA. She's supposed to have retired in July. And I think when she's not the head in dealing with their issues as far as having advanced nurse practitioners, having the legislative or having the medical power that they need or want, then she may be able to take a different tack. So that's on my to-do list.
Yeah, that would be good. I'd be happy to talk with Colleen too. If
Yeah. You know Colleen? I'm sure you know Ed from way back.
Yeah.
And he's still doing some private practice stuff. They had to go to some memorial service this week, and then we may be in the mountains for a couple of days over, Sunday through next week over the Jewish high holidays. And then after that, it's on my list to contact her. So.
Yeah. Okay.
Sure. Sorry I missed the first part of this. It's like, but
All right, we'll get
it's
you
been one
caught
of
up,
those
Shelley.
days. It's just been one of those days. Yeah. Anyway, and I'll just throw this out there. If anybody knows anybody who may be willing or looking for a place to live and is a non-smoker and would like to help with somebody with dementia, I'm looking for some in-home help. And I would provide housing for whatever. But I've contacted other groups, but I don't, immigrant groups want independent entries and kitchens and bathrooms and, things that are more private. And I think having a whole family with kids would be too much because of the situation I'm dealing with her. But if anybody can think of anybody who's a nursing student or somebody who might be interested or needs a place to live, let me know. I got a big house and I can be annoying, but I can try to get it under control.
Thanks, Shelley. And we did have another comment, and it's a really good one about contacting National Nurses United. And yes, I am involved with National Nurses United. I was lucky enough to work for them for 5 years. So yes, we certainly are working with them and helping get the word out and get our legislators on board. So
yeah, and I joined their Zoom meeting, and I'm going to be doing some volunteer stuff with them with writing postcards and stuff for different legislative goals that they have, especially.
Okay, Donna, we can get started. It's 5 after.
okay, yeah, let's get going. And Vince, take it away.
All right, this is the disparities groups, and you can see, boy, I didn't realize how many people would fall under this, but that's an issue that needs to be addressed, and it would be in this bill. So new benefits and preparedness in this new bill. There'd be more benefits. We talked about this: long-term care, dental, eye, hearing, no copays or deductibles, transportation for older people with functional limits. Medicare doesn't do that now. There'd be more protections. We talked about the banning prior authorizations. You can't take away any benefits from Medicare for all. And this is the one that, if we have another pandemic, that's really important. They would create 365-day stockpiles of personal protective equipment and other infectious disease preparations. We got caught really bad because of this lean policies that hospitals have adapted, that they wanted to function like Toyota, and they didn't want a warehouse of a lot of equipment and supplies. And they figured, because what they do is as they use them, they order them and they get new ones and they turn them over quickly. Well, you get hit with a pandemic where all of a sudden you have a demand for supplies that aren't out there, you're in real trouble. So this would address that. And hospital budgets would auto increase during public health emergencies. So if hospitals are overwhelmed and they're seeing far more patients than anticipated for that time period, there would be ways to reimburse them. Protected populations, TRICARE we talked about. There are TRICARE physicians in practice who do TRICARE. That's what the facility, TRICARE members would be included in Medicare for All. Protects VA benefits, and they would also be folded into Medicare for All. This is the Indian Health Service is underfunded and understaffed. They would be able to improve that. And of course, the tribe, they wouldn't be imposed on the Native American populations. They would actually have a say in whatever things are happening with their healthcare system. What about all those workers, the people doing billing and collecting for the insurance companies and the hospitals? Well, this bill has a minimum budget of 1% of the total budget for the first 5 years to assist displaced workers. Okay, and they'll do it in a whole bunch of ways so that this transition will not adversely impact people who no longer have the job they have now, and they have to transition. So there would be support to do that. That's taken into consideration. The way this 2-year plan will go, during year 1, the current Medicare enrollees can utilize the expanded services such as dental and vision care. After year 1, it would automatically enroll all newborns, all children under 18, and all adults beginning at age 55. There will be a way to buy into new Medicare. And after year 2, everyone would be covered, and everyone would be in the system. So enrollment available after 1 year, available to any resident over 55 or under 18. It would match the final Medicare for all design. Premiums would vary by age, individual, family, or tobacco. That really what they're doing is they're mirroring the way Obamacare premiums are determined right now. And it would be offered through the Obamacare exchanges. And the Affordable Care Act qualified employers can offer it to their employees as well. And all this ends when Medicare for All takes effect in year 2. This proposal is endorsed by most of the unions in the country, and they support Medicare for All. I didn't put some of the other slides in, but all the surveys in the last 5 or 10 years, when the question is asked, would people support a national single-payer healthcare system like Medicare, a majority of people across all, well, certainly all the independents and Democrats support it very strongly. And even now, a majority of Republicans are coming around to support this. 59% of providers now support single-payer healthcare. 59%, so the majority of providers. This is a great read if you want to learn a lot more about this to access. It's online. It's from the British Medical Journal called The Lancet, and it was published in February. They took, as an outside entity, they took a look at healthcare in our country and said, it's a mess. Here are some suggestions on how it could be improved. And they go really, really in great detail, and it's really well done and very objective about how we can improve our healthcare system. And their bottom line is to establish some type of single payer national health insurance program. And they did a financial analysis. And in the future years, next year, I guess it was actually this year, they said if you expanded the healthcare insurance plan to cover everybody now, and we continued with the multi-payer system we have now, that would raise the price to 3.636 trillion. If you had a single payer system, it would actually decrease the cost to 3 trillion. So you'd save $606 billion, $30 billion. And not only would this single payer universal health system save it's actually $458 billion. It would save 68,000 lives. We are losing 50 to 60,000 people a year now because our fragmented, dysfunctional healthcare marketplace with all the uninsured and the underinsured people, or people who can't afford their insulin or their prescription drugs. We would save lives with this program. So it would cover everybody, no copays or deductibles, comprehensive benefits we discussed. That was the 10 benefits plus long-term care now, free choice of provider and hospital, reduce the nation's costs. How can we afford all this? Because our political leaders, including certainly the Speaker of the House and Senator Schumer, and I think President Biden, have all said, how are we going to, we can't afford this Medicare for all. I don't understand why they don't understand the stuff we just talked about today. It's not that complicated. It just takes an open mind and to exclude the special interest from your deliberation, and you'll figure it out. So how can we afford it? Well, this study was done back in 2017, so it's a little old, but basically it shows spending without reform that year and the savings with single payer. The biggest savings is the insurance and administrative overhead for the insurance companies and the hospitals and providers. And you can see the billing, and these are the savings. So let's look at this. The current sources of our $3.8 trillion funding, if you really look at it, it's the federal government tax dollars that are funding 53%. That includes Medicare, Medicaid, tax deductions for private insurance premiums, and private insurance subsidies like Obamacare. If you add that all up, taxpayers are funding 53%. 53% of our 3.8 trillion goes to fund this. State and local governments actually fund 17%, because remember, they fund a portion of Medicaid, usually half or 60%, unless it's expanded Medicaid, it's less. And they have all the private insurance premiums to pay for all of their people who work for the state and local governments. They get health insurance and they contract with private insurance companies. So that adds into this. And the employer and employee private insurance premiums fund the rest of this. So basically 70% is funded with tax dollars directly or indirectly. 30% come from employer and employee private insurance premiums and out-of-pocket expenses. So that's 30%. So that's where this current sources of funding come from. If you're financing Medicare for all, you would have to repurpose, and in fact, the proposal is to repurpose all of the current federal funding. So basically, you keep what the federal government is paying now for Medicare, Medicaid, tax deductions and subsidies, and take that money and apply it toward the publicly financed single payer health insurance. Repurposing the current state and local government spending. Again, financing the Medicare for All program. And you then have the private healthcare spending, that 30%, we would have to figure out a way to pay for that with progressive taxes. But remember, the private insurance premiums go away. And that averages $24,000 per year for a family of 4. So they're saving $24,000. And now there's going to have to pay some type of taxes or premiums that will be progressive, not regressive as much of healthcare costs are now. We went through that last week with progressive taxes. So what are some of the funding options? And these have all been discussed, one form or another, a flat or progressive payroll tax. Flat or progressive. Right now we have a flat Medicare tax. We could do a progressive Medicare for all payroll tax. There's talk about, since employers are paying most of the private health insurance premiums now, that they continue to pay some type of tax that replaces the payment they're now making for private insurance premiums, and it would go down. A value-added tax. Several European countries do this. That's sort of a fair way to do it, because the wealthier you are, the more you spend on stuff, the more tax you pay. And so some European countries are doing it that way. A wealth tax or a combination of the above. So it can be done. And when you say you hear the politicians screaming, our taxes will be increased and people can't afford it. We'll take into account what they're paying for just premiums alone. I mean, even if you had to pay 8% or 10%, you'd have to get above $240,000 to be paying more for your health insurance than you are now. I mean, it's just absurd that people refuse to stand up and say, wait a minute, we're going to have all these savings, particularly the expensive premiums. And so we got to pay some additional taxes. So Medicare for All makes economic sense. There have been 29 fairly detailed studies that say the savings would fund full coverage of this new program. And I'll show you those in a minute. And a couple hundred economists say it's time for Medicare for All. And healthcare is not a service that follows standard market rules. We've shown you that. Free market competition does not lower costs in healthcare. It absolutely does not do that. This healthcare should be provided as a public good. These are most of those 29 studies. The red bars are the increase in cost, what the increases would be, and the green is the savings. And you can see the majority of them project the savings. And because they're so different, they've made different suppositions about a lot of stuff. And if you want to read about this, I'll show you the book to go to. That's the best book currently out there on Medicare for All. And again, here's the projected change health expenditure after 1 year after the switch. Most of these studies show a savings. 2 of them show an increased cost. And again, it has to do with how they modeled the studies. Potential cost and savings under Medicare for All. The cost, what would be the additional cost? Well, clearly additional utilization, because we're now going to cover everybody. And there's 30 million people right now in the country with no health insurance. And we're going to also incentivize people to get care because underinsurance will go away. So that there's going to be increased utilization. And people said, well, this is going to break the system because it's going to overwhelm it. And I'm not going to burden you with more slides, but basically when they looked at the transition in Canada from basic private fee for service to their Medicare for All, there was no significant increase in utilization in Canada. And the same thing for the most part would happen here. There would be some. We would have to increase, in fact, do away with Medicaid and make it Medicare. And therefore we would have to increase the rates that are currently reimbursing providers through Medicaid and increase those. So that's an additional cost. There's increased benefits that we would have to, the increased benefits, the big one being long-term care, which we'll get into. That's going to have an additional cost. The savings we just talked, some we would negotiate discounts and pricing for pharmaceutical and durable medical equipment and devices. We would control the provider payments, and it would be the Medicare rate plus, some people are saying, an additional 10%. I've been informed by a couple of private insurance executives that they feel they can negotiate a good, or by a hospital, that they can negotiate a good deal with an insurer if the insurer pays the current Medicare rate plus 35%. So we can pay the Medicare rate plus maybe 10%, not 35%, and get costs down, savings there. Clinical efficiency, elimination of a lot of redundant studies and tests, because if you have a single healthcare system, you have a single medical record. And that is really important, to be able to access people's medical records to determine whether they show up in the ER. And, you know, maybe they can't even give me a history, but if they had a study done last week that I'm thinking we need to do now, and we could access that, we don't have to do this study today. And we could identify early on fraud because we could find the outliers, because they have to bill the insurance company, to bill Medicare. And if you have an outlier who's billing for a provider, billing for a lot of stuff that other providers of the same specialty in the same area don't bill for, you say there's something wrong with this system. And this is how they identified the Medicare fraud in McAllen, Texas, many years ago, where they had people doing all kinds of unnecessary bills, procedures, and consultations. But this could be picked up early and limited. Administrative costs, we've talked, the billing costs, the overhead costs for the hospitals particularly would be dramatically decreased. Private insurance would go away. The hospitals would be globally budgeted. Providers would be able to bill a single payer, not have to negotiate discounts, not have to worry about billing multiple providers and doing battle with them to get paid. So additional cost, we talked about the elimination of copays and deductibles, covering 30 more million people, covering the underinsured so they're no longer underinsured, increased Medicare provider payments. I just mentioned this one, funding the expanded benefits. We talked about dental, vision, hearing. but long-term care. This is a wild card in this whole deal, because I'll show you why in a minute. And of course, the 1% a year for 5 years to retrain displaced workers. Here's the issue. Here's what it cost for a long-term care nursing home facility in 2020. On average, $105,000 for a private room, $93,000 for a semi-private room. So the nursing home costs right now are $93,000 to $106,000 a year. The assisted living facilities are about $50,000 a year. And in-home care, the average there is $24 an hour. Unfortunately, that's not what most of the providers get paid, because they're working for-profit entities as well. They probably get paid $12 or $15 an hour. Hopefully that could be fixed. And depending on how much home care is needed, you can go up as high as $55,000 a year. Here's a dramatic slide. Here's how much, since 2004, the cost of nursing home care has gone up. And one of the big reasons here, back in 2004, a significant number of nursing homes were not for profit. Some of them were even government kind of funded places. And then the private market got into it, and the for-profit entities start taking over. They now own 85% of nursing homes. And look what's happened to the cost. Dramatic increase. The same thing to some degree with assisted living and in-home care costs. And we talked about one of the sessions, 6.5 million people we know of in this country now have dementia, most of them Alzheimer's, and they require 24-hour care or have to go to a memory center, which is basically a long-term nursing home for people with dementia and memory issues. And that's very, very expensive. And if Medicare is going to fund all these costs, this is a huge, right? Well, right now, Medicaid is funding them, but not at the same level. So you would fold in what Medicaid is paying now, but add the additional costs. So this could be a game changer in terms of the cost, and would have to be factored into how we're going to pay for this new system. So the cost savings from the current marketplace, elimination of private insurance premiums, copays, and deductibles. Private insurance companies go away. They no longer exist, which is good because they add no value to our current healthcare market, to our current healthcare in this country. They add a lot of value to their bottom line and their pocketbook. The out-of-pocket dental, vision, and long-term care, that's, cost savings would be, the individuals would no longer be paying as much for dental, vision, hearing, and long-term care out of their pocket. The Medigap and Medicare supplemental insurance, it would go away. There's no need for it. The Medicare Advantage premiums, copays, and deductibles would go away because Medicare Advantage would go away. They're a private insurance company. We no longer need to have them managing your Medicare. Here's one people don't think about. You pay extra on your auto insurance policy for medical costs, and uninsured motorist and all of that stuff, and medical costs. Well, that goes away. It would also go away the medical part of malpractice settlements, because if the person harmed survived, every part of a medical malpractice settlement includes how much will it cost for medical care for this individual for the rest of his life. That goes away because they're covered under Medicare. The marketplace savings would be, remember we talked about, what was it, $30 billion a year is currently spent on marketing, selling prescription drugs, direct to the consumer marketing Medicare Advantage plans, marketing. I mean, the airwaves are just saturated with this. Well, if the private insurance market goes away and the for-profit hospitals go away, there's no need for all this money to be spent on marketing. The billing and collecting, we've talked about multiple times, that goes away, except you still got to, there still has to be some, but it could go down to as low as 2% rather than 20%. The PPACA subsidies, the Obamacare subsidies for private insurance companies, they go away. They're up to about 400 billion a year now. They go away because private insurance goes away. The Medicare Advantage subsidies, where there's a lot of fraud and abuse in that system, they go away because Medicare Advantage goes away. The tax deductions for private insurance goes away because there's no longer private insurance premiums. And we can decrease, I think, a significant amount of the current waste, fraud, and abuse in healthcare. And that's a big savings. What about businesses? How are they going to come out ahead of this? Which surprises me why businesses are not at the forefront of supporting this kind of plan. Well, first of all, it would eliminate the workman's compensation medical coverage premiums that all businesses now have to pay. It would eliminate their health insurance premiums, which if you watch the movie Fix It, it shows how difficult this is for a businessman to have to every year negotiate which private insurance company he's going to have provide coverage for his employees. So all these annual negotiations and administrative overhead that they face go away because their Medicare for All is the system. And this one, people don't think about this, but if you have a business and you have 60 people in your business and you're insuring them and you're insuring them at a certain premium this year, for example, and one or two people get very expensive illnesses like cancer with chemotherapy or some very expensive illnesses that cost millions of dollars, the insurance company doesn't look at it as, well, we're United Healthcare and we insure 40 million, 50 million people, and that's just folded into that group. They look at it from the 60 people in your business. And because you've cost them so much more money in 2021, they will dramatically increase your premium in 2022. That is a real problem for businesses. That goes away. Traditional Medicare is efficient. This just compares the insurance overhead with Canadian Medicare at 1.8%, traditional Medicare here at 2%, private insurance at 12%, and that Medicare Advantage is closer to 17 or 18%. And that shows you that, and all of this is savings. And this is just different studies where they said, here's where the savings are. And you can see because they modeled them so differently, but they all show savings in administration, that's the blue, reduced reimbursement rates, that's the green, prescription drug and medical device pricing, because they negotiate these prices, that's the red, and it kind of varies because of the modeling, but they show significant savings. So single payer Medicare for all makes economic sense. New expenses in this model, this was from Paul, and yeah, this is a 2018 study. The new expenses we talked about would add 12% to what we're currently paying. The new savings would be 19%. The 12% increase is increased utilization and increase in what the insurance would pay for. The savings would be administration, market decrease there 9%, pharmaceutical pricing, they estimate 6%, uniform rates on delivery 2.8%, fraud and waste, they estimate 1%. I think that would be higher, but anyway. So that's the savings. New expenses, new savings. And savings are not funding. Savings are savings. So you don't need to fund as much. In 2017, we were paying 3.24 trillion for healthcare in this country. If we increased utilization that year by 12%, that would take the cost up to 3.63 trillion. But if we had a savings of 19%, that would bring the cost down to 2.93 trillion. So you would cover more people, very comprehensively for less money. So that's really the bottom line here. So if we can pay for the status quo, we can pay for a program that's less expensive. This is Dr. Gerald Friedman, who's done several of these studies. So, questions or comments?
You can go ahead and unmute if you'd like, if you have a question or a comment, or you can wait until Vince completes his.
Yeah, until I end. It won't be too long. All right, let me go on. Impediments to healthcare reform, and this is the real rub. The special interest, the medical industrial complex. We've showed you in previous talks, they spend 2 to 3 times more on lobbying than any other special interest group in the country. It includes the military industrial complex, it includes oil and gas, it includes all the special interests. And what many consider waste and abuse, they consider salary and profit. And this is the rub. They make huge contributions, so not just federal, but state legislators. And this one, I don't know when we're going to get by this, if at all. Unwillingness of our legislators to look at the facts and work together for the public good. Man, can you imagine if that ever happened, how nice that would be? But I guess we're dreaming. So the impediments here is the army that's been formed to fight Medicare for all or anything that approaches it. And that army is primarily funded by pharma, insurance companies, and hospitals, and other groups as well. We'll get into that. This dark money group, last year when the Colorado legislature was seriously considering a bill to provide a form of public option for certain people in Colorado, all of a sudden $1 million popped up to fund a public relations campaign against this proposal. And this was funded by Partnership for America's Healthcare Future. If you go to their website, boy, they are just great people, this Partnership for America's Healthcare Future. They want to have equal access. They want to improve quality. They want to protect our most vulnerable. Now that is a real joke, but that's what they say. They want to strengthen the employer-provided coverage because this is the best thing since sliced bread. And they want to preserve control. They want to empower the patients with more choice about their healthcare decisions. And they're doing just the opposite by supporting private insurance companies. So this really looks good. Who are these people? Well, here is who's in the Partnership for America's Healthcare Future. Every for-profit hospital system, every private health insurance program, Big Pharma, which is the umbrella organization for all of the pharmaceutical industries, and surprisingly, a huge number of chambers of commerce. which represents business in their local community or state, I don't understand why they are so fixated with preserving the current status quo when there is so much money to be saved by the business community if we made the transition to Medicare for all. But this gets better. Here's the rest of them. You can see what a huge number of special interests are in this partnership for American, whatever it is. The AMA was a member of this group, but to their credit, the student section of the AMA created such an uproar in the last year that the AMA actually took themselves out of this. So there is hope. So that's where we're at. And then the other impediments, besides the medical industrial complex, are these two people. Schumer says the cost of Medicare for all would be so huge, we'd be broke. Boy, is he drinking the special interest Kool-Aid. And Speaker Pelosi says that, let's use our energy to have health care for all Americans. And that involves over 150 million families that have it through the private sector. So and along with the president, of course, he's fixated on improving and expanding Obamacare for all. Translated means let's just throw many billions of taxpayer dollars to subsidize the private insurance marketplace, which makes premiums affordable for many people, but it doesn't take away the hassles of having a private insurance plan. You don't have free choice of doctor and hospital. They create hassles for you in terms of medical care. You end up with huge deductibles. Sometimes many people can't afford them. That doesn't go away with increasing subsidies to private insurance companies. That stays. It goes away with Medicare for all. The best book that's out, this is a superb book, it came out past year. Medicare for All, A Citizen's Guide. This is a great book. So if you want to really have a better understanding than what I can give you in this 8 hours of talking to you, get this book. It's an easy read. It's easy to understand. And this person, Abdul El Sayed, was the public health, head of public health in the city of Detroit. He also ran for governor there last time. And Micah Johnson is a very smart guy, physician. And together they wrote a wonderful book. So thank you again from Healthcare for All Colorado for attendance and participation. And here are the top 10 reasons to be against single payer healthcare. Questions, comments?
Wow, Vince. Yeah, we had one comment in the chat about how do we deal with the filibuster being a problem. And I think you answered that question by telling us that, you don't even have to worry about the filibuster if Schumer is already hung up. There's no point because he'll keep his Democrats in line to fight it.
Yeah, the current leadership is not even seriously considering this proposal, but somehow they're going to have to realize how much money they're throwing into a system that doesn't work well for a lot of people. I don't know how we're going to get that message to them, but 117 people in the House, I think, understand that because they're co-sponsors of the bill.
Yeah. Yeah, and here in Colorado, those of us who know anything about our senators here know we have a real problem with both senators, Michael Bennet and John Hickenlooper.
Yeah, I didn't get into Medicare for X and Medicare this and Medicare that.
Yeah.
All they are is ways to subsidize the private insurance industry.
Absolutely. Well, thank you so much, all of you, for joining us. The recordings will be completed and they're processing later on this week, and I will send out to everybody who has participated. I'll make sure you get a message with all of the recordings and Vince's slides. And Vince has been very generous about saying you may use them to educate people. They will also go up on the Healthcare for All Colorado Foundation website for you to use from there. And we're hoping, I have been chatting with some of the local librarians about perhaps getting these on file with the Denver Public Library. So it would be really wonderful. Kristen, actions to take right now. I think the best we can ask for in National Nurses United is certainly asking for help with some legislators and getting them on board. We'll try and get a message out to everyone early next week on who's still a holdout. Colorado's Democratic delegation is pretty strong right at the moment, so we're pretty lucky about that, but not on the Senate side, but we're not there yet, so we're not concentrating.
There are a large number of cities that have passed
Yes.
their city councils Medicare for all support, right? How many, Donna? Do you have any
Oh
idea?
gosh, 100 and some have passed resolutions at the
And
city
some of the
level.
major cities are on board
Yep.
because they realize they would need this to cover the homeless in their city and all the other people that really need health care.
Oh, and Lydia, wonderful point about Jason Crow. Jason Crow's office, we have been meeting with him periodically. Progressive Democrats of America, Colorado's chapter, has been meeting with him, and we met directly with Jason Crow. And boy, he is on board with that Medicare Act, buy-in to Medicare routine, and he's going to take some more work. So last time we spoke to Jonah Goose, we said, hey, something you can do for us, talk to your buddy Jason Crow. Some of that's going to take pressure from their fellow legislators, telling them that they need to really get on board. So much more about this. If you want to know more about the advocacy, the political side of this, Healthcare for All Colorado, not the foundation, but Healthcare for All Colorado. We're lucky to have Lydia Guzman here, who is the president of the advocacy side of the House. And please follow us and go look up our websites. I know Lydia would be happy to answer questions for folks. And thank you all so much for participating. And we hope to see you again. We will do more presentations in the future. And we'll hope that you help us get these out there deeply in your communities. Good night, everybody.
All right, thanks, everybody.
Thank you, Vince, for an excellent series of presentations.
Oh, you're
Super.
welcome, Eleanor.
Thanks, Vince.
Thank you, Vince.
You're
Yes,
welcome.
Kristen, that's true about Crow and Bennett. Yes,
All right, thanks, guys.
thank you.